Ladies and gentlemen, and welcome to the next in our series of COVID videos and webinars hosted by the Royal Society of Medicine, designed for health professionals and by health professionals. Can I take the opportunity to remind you of our Q&A function, and we will do our very best to keep up with the questions as they come, but we know that we're not going to be able to answer all of them in the next half hour. We will be having a special kind of panel show in a couple of weeks' time to get round to so many of the questions that we've actually missed. Now then, so to my guest today, it's Professor Peter Openshaw. He's the Professor of Experimental Medicine at Imperial College London, and he's basically Mr. Respiratory Infection, and as such, very much the man of the moment. You probably saw him on Question Time last week, and indeed on virtually every other news channel ever since. Now, Peter, let's start off. So you were introduced last week as a member of something called Noatak, which apparently is one of these government scientific committees. Explain a little bit about what that job is that you do.
Yeah. So this is a scientific committee which is not a secret one. So the membership of Noatak is public knowledge. Yeah. Unlike SAGE. So Noatak is a committee which has been running for something like 15 years. And it's basically horizon scanning. So most of the time, Noatak gets together a few times a year and looks at what's coming over the horizon in terms of new respiratory threats. Mostly we talk about avian influenza viruses and maybe mutations that are going on in influenza, and whether there's anything else which looks like it might be a little bit dangerous. But I think the fact that we've all got to know each other over time, and there's a variety of expertise. So there's about maybe 40 people who are members of Noatak, and with different levels of expertise in different areas. So there's a smattering of us clinicians, a few immunologists, not many. I'm really, I suppose, the main immunologist, and there's virologists and so on. So quite a range of different expertise, and that feeds up through Department of Health, particularly through Jonathan Van Tam, who's deputy to CMO. So yeah.
Okay, so you've been going for a while, but I think, is it true to say that the coronaviruses were, for quite a large part of your career, regarded as a little bit recherche, not particularly interesting, possibly even dull?
Yeah, quite frustrating. Frustrating to work on. So I mean, they were studied at the old Common Cold Unit that was set up on Salisbury Plain before the MRC closed it down in Margaret Thatcher's time. And that was a really wonderful unit where David Tyrrell did studies on coronaviruses, which he was involved in discovery of back in 1960 or so. Steve Mint and others tried to infect people with those common cold coronaviruses and found it immensely frustrating because the take-up of the volunteers was quite low and erratic. So difficult viruses to work on. Nobody could really be bothered to make a vaccine because they contribute 15% of common colds, but not usually very serious ones. So I think we knew about coronaviruses a bit, but with SARS and MERS, I think we all sat up and got quite alarmed. I think SARS was a very near miss. That could have been a global pandemic of a virus that has had a 10% mortality. So, 10 times the mortality of the current COVID-19 outbreak. And that was a near miss, I think. When it spread to Toronto, many of us were really so relieved in 2003 when it was eliminated by public health measures.
Well, the obvious question then is, if SARS was a near miss, how come COVID has become a hit?
It's just that bit more infectious, quite a bit more infectious. It seems to have an amazing ability to infect. And I think one of the particular characteristics is that because it causes quite mild disease and maybe no disease at all in 20% or so of people, maybe 30%, those people can be transmitting it and not even know they're ill. Whereas with SARS, people were typically a bit more sick and it was easier to identify them. So altogether, asymptomatic or pre-symptomatic transmission is happening in almost 50% of cases. So that makes it much harder to control, especially if you haven't got widespread testing and identification of those carriers or spreaders.
Mm-hmm. Now, of course, you're a clinician yourself, and I understand you've got some new research out very soon, which is looking at what we haven't heard so much about, the kind of clinical aspects of the disease and how it evolves. Can you give us couple of the headlines? You know, I don't want you to steal your own thunder. Well, actually,
No.
I do want you to do that.
But I'm not
don't worry, you're among friends. No one's going to mention it. But tell us a little bit about what that's showing.
Nobody is listening, I'm sure. So
that's right.
I mean, actually,
2,000 people.
Actually, the Chinese were remarkable, I think, in sharing very early in the outbreak their clinical experience. And, you know, I know that there are different views about the role that the Chinese have played, whether they've tried to cover stuff up. My personal experience has been that the Chinese really did let us know as soon as they possibly could what was going on here. So in terms of the pattern of disease, I think you can sort of divide it into different phases. So maybe the first phase is the pre-symptomatic. So after you've been exposed to the virus, it takes on average about 5 days to become symptomatic. So there's a lot of interesting immunology going on in those 5 days that we don't really know much about because you can't easily study it. But you know, I think that's an important phase. Then you've got the early symptomatic phase when it's replicating mostly in the upper respiratory tract, spreading down into the lungs. And the upper respiratory symptoms are often mild or inapparent. So people may or may not have common cold symptoms, only present in maybe, I don't know, 5%. But then lower respiratory tract is mainly where the symptoms develop of cough, maybe a dry cough, slight fever, occasionally hemoptysis, but and then after that, so normally most people get better. So 80% of people get over that acute lower respiratory illness. And then a proportion, it sort of comes back to bite them again hard in terms of as the immune response is really cutting in with lots of intense cellular immunity and cytokines coming out into the lungs. You go into this third phase, which is the sort of respiratory failure stage when you get very short of breath, where maybe you may need mechanical ventilation. And that's the phase which is causing so much trouble in our hospitals at the moment.
Okay. Well, I'm getting lots of questions on vaccines and treatments, but don't worry, folks, we will get to that. But sticking still then with the immune side of things, your particular skill and expertise, I mean, it's obviously much more difficult than we expected to nail this antibody test. We've had to throw away 3.5 million testing kits. There are 20 universities working on this, including yours. And yet still not nailed. What's wrong with you all, Peter? Why haven't you managed this yet?
Yeah, it's not easy, Simon. It's not easy.
That's no excuse.
There've been some really great people working on this, and I think we should, give a tribute to the scientists who've been working day and night, particularly at Public Health England and elsewhere, to develop really good antibody tests. You know, these are people with enormous expertise who spend a lot of their lives completely sort of out of the public eye, just working diligently in the background. It's not easy. You have to make a test which differentiates this virus from other coronaviruses. So you don't want it picking up people who've had a common cold coronavirus, and you don't want it picking up people who might have had MERS in the past or even SARS. You know, it has to be specific. So that's one of the challenges. You need it to be very sensitive. Now, these tests, you referred to the 3.5 million tests. I think that these weren't actually tests that we had already shelled out for as a nation and we bought and are now useless sitting in a warehouse. I think these were tests which were sort of pre-ordered pending the results of evaluation. And the evaluations have been done through John Bell and others in Oxford. And essentially those rapid antibody tests that were offered have all been found wanting in terms of sensitivity and specificity. You know, our own teams in the UK have now developed some really great assays, and those are being run at Porton Down and are being used first to inform the epidemiology and to tell us just how widespread the virus infection has been. And subsequently will be rolled out, versions of that will be rolled out elsewhere, which will be really useful in letting people know whether they've had the virus in the past. But remember, those tests are not the test for active infection. those are tests which tell you whether you've been infected before, which is really important.
You know, someone's just asked, I'm afraid the name flashed past very quickly, but is the serum antibody test the best thing we actually could be measuring?
Well, I think it is in terms of past infection. I don't think anything that we could measure in terms of cellular immunity would be more informative in terms of whether people have had it. Clearly, the test for the virus in the upper respiratory tract is the key test that's been used so far. So based on PCR, there may be other ways of detecting viral antigen, but remember that that is dependent on the quality of the swab that's been moved around inside your nose, or swabbed around inside your throat. And we know that quite a lot of those swabs are not really being taken in the optimal way. And the virus may be down in your lungs, causing a lot of cough and shortness of breath, but not actually up in the nose. So, the failure to detect that virus in somebody with typical symptoms, I don't think should be regarded as a test that rules out the possibility that they do actually have COVID. And indeed, at one stage, the Chinese extended their definition to include people with typical findings on CT scan, because the CT can be so characteristic that anyone who's used to looking at CTs of patients with COVID, won't mistake it for anything else. It's a very characteristic change on the CT. So okay. Sometimes you miss the virus, but you can see that this is typical.
And on that subject of antibodies, Stephen Chalicum has just come in and asked for, is there a role for mucosal Sig-A antibodies now or later in immunity to coronaviruses? I think he means in general.
A very well-informed question, as we'd expect from Steve Chalicum. Yes. So
it is that, Stephen, is it? Okay.
I guess. So certainly it would be great if we could develop a test which is based on detection of antibody from the junction between the tooth and the gum. And indeed that sort of test has been done for some other infectious diseases. And the great advantage is you can just wipe a swab around that junction and you get a sort of oozy fluid, which is not exactly saliva. It's really partly, about 1% of it is actually the serum. And so then you can get a test without needing to do venipuncture or a finger stab, and from which you might be able to tell whether there's antibody present. But my understanding is that that's not necessarily secretory antibody. It's more antibody which is sort of transudated or exudated from the margin. But Steve might be able to tell us more about that.
Okay. And then a couple of clinical questions. One had never occurred to me at all, but it's asking about Ecigs and the water vapor that it produces. Is this a particularly potent way of transmitting the virus? It never occurred to me, that one.
No, I have wondered. You see people with e-cigarettes generating these massive plumes of vapor, and you think, wow, that is how far an exhaled breath travels. But I've seen no evidence that that actually transmits virus. You can imagine that maybe inhaling those droplets down into the lung, it could scavenge virus, and then as you breathe out, then some of those droplets might have virus on them. But I don't think there's any evidence for that at all. No, it's an interesting idea.
George Drax's.
Yeah.
Okay, George, so that was your question. We're not entirely sure.
Yeah.
But again, lots of people now are asking, so Mary Lois, Sue Searle, and many others, and the basic question, putting them all together, is will those who've been infected be able to be infected again? So obvious question, important question, do your best.
Vital question. This is a novel coronavirus. I mean, we don't know because nobody has been reinfected after a long enough period for us to have any idea how long the antibody or the immune protection might last. I mean, I would say that the sort of lower limit, the worst possible scenario would be that you would be protected against reinfection for maybe 3 months. It could be that then that level of protection wanes and it's possible to become reinfected. My bet is, I would put about 80% on the likelihood of immune protection being much more long lasting and being protective for well over a year, possibly 5 years. So, you know, there are many concerns and doubts about the durability of protection, but I also do hope that the approaches that are being taken to vaccination will induce an even better antibody response than is generated by natural infection, and that vaccination might actually confer much longer lasting protection, particularly against the lower respiratory tract element of the disease, which is really what we want to prevent.
We'll come on to prospects of vaccines in a minute, but just want to go back to another clinical question that's come up a couple of times already. Now, there seem to be both gender and ethnicity differences in the prevalence of the disease and in the outcome. Now, some of those, the epidemiologist in me can explain by all sorts of epidemiological reasons, but are there any from your perspective, an immunologist or a virologist, that could be relevant?
Yes, so very important questions. So the genetic control of the immune response is something which has been researched a lot, and all of us is a rich matrix of immune competences and incompetences. So, you know, I remember one study hinted that we all have maybe 40 different gene variants which affect immune responses, which are making us particularly good at one particular type of response or poor at another, and vice versa. So we're all a rich matrix of these different immune genes. I mean, in the 2009 influenza pandemic, we identified a novel variant of a gene called IFIT-M3, which is present in about 1 in 400 of the Caucasian population, but 25% of the Han Chinese, and about nearly 70% of the Han Chinese in hospital with H1N1 pandemic flu were carrying this abnormal form of the gene. So, you know, I've no doubt that there are genetic variants that will account for some of that variability, but we're waiting for those to be defined. And that is indeed one of the targets of our ISRIC-4C study, which has been launched in the UK, with Kenny Bailey in Edinburgh being one of the world experts on the host genetic response and how it affects viral infection. So obviously that, you know, host genetics could be a factor, but clearly there are many demographic factors. We know that, you know, poverty is associated with poor health outcomes in almost every domain, and this is absolutely one of them. And the reasons for that are many and varied. But there's no doubt that ethnic minorities are being hit much harder than those of us who are affluent and well.
Yes, that seems very clear. But even taking account of poverty, if you just look at doctors who we'll have to assume are reasonably well paid, it still seems to be ethnic minority differences already emerging there in those who are getting sick and dying.
Yes, yeah. I think it also may depend on the intensity with which you're exposed to the virus. We don't know that exactly, but it certainly whenever models of infection have been set up, then one of the first things you do is a dose escalation, and you can see that the more virus you put in, the more the frequency of disease climbs and the severity of disease climbs as well. So I think dose has to be something to do with it, but it's not quite clear yet in COVID-19 that is a factor.
Now, Peter Borg, who I'm guessing from his name, as my wife has just walked past me, must be Maltese, very keen on treatments here, and is asking specifically about ACE inhibitors. Could they have a role?
Very interesting. There's been a long debate right back from the moment that it was identified that the ACE2 receptor is the major receptor for SARS-CoV-2 and indeed for SARS-CoV-1. So, and the association with high blood pressure was obvious from the start. And that's not an association with severity in things like influenza. So that was a novel association. You know, heart disease is the major risk factor, and hypertension is a major risk factor for COVID-19. So the question has been, you know, is this something to do with that receptor, or is it something maybe to do with the treatment? The only information we've got so far is a study which looked retrospectively at what sort of drugs people had been on. and actually came to the conclusion that being on an ACE inhibitor, if anything, gave you a bit of an advantage compared to not being on an ACE inhibitor. But that study was rather confounded by an imbalance between the use of ACE inhibitors in those with and without diabetes. So I think, again, that's a factor which should come out of the ISRIC 4C study, where we're collecting very detailed information about drug use prior to hospitalization.
And as you are taking the trouble to do this webinar for us, I believe you're recruiting for the ISRIC study at the moment.
Yeah.
So can we ask all clinicians, please, to help with that? Presumably you have a website for that we might.
There is a website for that. Yes, absolutely.
There is. Okay.
Yeah.
So Icirik then, as in slightly like Icarus, but not quite. Again, it is absolutely vital.
It's the opposite of Icarus. That's a good way of putting
it. Oh, okay.
His wings are getting stronger as they beat.
Yes, that probably wouldn't be a good acronym, would it? No, you're quite right there. Okay, and still on treatments then, you began talking about how the cytokine storm is one of the lethal outcomes in COVID infections. What are the prospects there for intervention?
Yeah, so we've been measuring the cytokines in some of the samples of the serum, and we're about to measure some of the cytokines also in the respiratory secretions that we've been obtaining from these patients. And we've seen that there's very abundant IL-6 and IL-1. So these are immune mediators which are very important in recruiting cells and activating cells. And it does seem from our studies and from other people's studies that having a lot of these cytokine mediators around is associated with a bad outcome and going on the ventilator. The question's always been, well, what would happen if you inhibit those pathways? And there are some, as yet, uncontrolled studies showing that inhibition of IL-6 using a treatment called tocilizumab, which is an IL-6 inhibitor, seems to be associated with a rapid resolution of fever, a reduction in the need for oxygen and ventilation almost within 24 hours. Now, these are studies that were, as I say, uncontrolled, but it's very important, I think, that we do go ahead and do proper controlled studies rather than just assuming that we have to use these very expensive drugs, of which there is a limited supply for treatment in a clinical situation. It's absolutely vital that controlled trials are done.
Yeah, we'll end on that because it is absolutely vital, as you say. And then we've also got a few questions coming from pediatricians. Richard Nicol here is the neonatal pediatrician, asking very specifically about newborns and preterms. He said, why are they not affected, given that their immune system is so immature?
Yes, well, I would love to know. I had a 5-year welcome program on looking at the differences between neonatal immune responses and those of adults. And rather came to the conclusion that many of the things that we have hitherto studied in adults do not apply in the neonatal period, but still many infections are fended off perfectly well. It's really hard to study immune responses in a very controlled way, getting invasive samples from babies. That's what we'd really love to know much more about, how infants do manage to fend off infection and why they have certain holes in their responses.
I'm guessing that you have a bit of a clue, Peter.
Well,
what would your clue be?
Well, I think they seem to have good innate responses. It is interesting that very young children were at high risk of severe complications of influenza. But that's in complete contradistinction to what we're seeing with this novel coronavirus. So we really don't know, actually, Simon. I would really love to know more about why it is that infants and young children are not affected. I mean, up to the age of about 19, there's hardly any severe disease at all, and very little of it in the ensuing couple of decades.
Okay. So again, coming up a lot, and you know a lot about this, is the vaccine prospects. So Sarah Gilbert at Oxford, you you used 80% before, that seems to be the percentage of the day. She's 80% certain that her team are weeks away from developing a vaccine. Is this brave talk? You welcomed it in the Sun and said, you were optimistic about this, but tell us a bit more. Why are you optimistic?
Well, I think Sarah Gilbert's approach of using a chimpanzee adenovirus, which is genetically engineered to encode the spike protein, provides both a method of amplifying the vaccine, growing it, and also of adjuvanting the immune response, because the chimp adeno acts as a sort of natural adjuvant to the immune response. Mm-hmm. And she has very, very good experience of using this, trying to develop vaccines for other things, including coronaviruses like MERS. So there's all that background that's been done. She's an immensely methodical and efficient scientist, and she will move through the stages at great speed. And I must say, supported by people like Adrian Hill and Andrew Pollard in Oxford, they have a fantastic setup for developing and testing vaccines. I think the most important thing is that somebody steps forward to try to actually fund the production of that vaccine, despite the ongoing uncertainties with continuing clinical trials, because you can't just scale up immediately. You have to put that in place. So I really, really hope it's going to work, because it's the only proper exit strategy we've got, is that one of the 100 or so vaccine approaches that are being taken is going to actually work. So.
Okay. Well, nicely on cue, Mr. Husham Al-Darari has asked, what trials should I be recruiting my patients to at the moment? And I think we're going to make a fixture of this. We're going to ask all the clinicians to recommend a good trial going on, because it's absolutely vital that clinicians up and down the land support the clinical trials going on. So can I ask you then to tell us about just one trial that's going on at the moment that our clinicians can recruit to?
Could I just, by way of preamble, say, please don't recruit to uncontrolled studies that are not going to provide any good solution. There are many companies coming forward saying, "Oh, give this a try." Please don't do that. Do go for one of the big national studies.
Absolutely.
And I particularly commend to you the recovery trial, which is being run by Peter Horby. That's recruiting very well. It's very easy to recruit to. It's really directed at fairly early disease. That study is a really beautifully designed study, which has enormous power and will recruit large numbers of cases. But I think the REMAP-CAP study, you asked for just one, but I'm giving you two. The REMAP-CAP study in intensive care, which Tony Gordon is the national lead on. It's an international European study, and that's looking at the more severe cases and looking at the immunomodulators, the immune blockers. So that's the one for later on.
And we will continue to plug the NIHR Be Part of Research, part of their website, Be Part of Research, NIHR AC UK, that will list and does list the currently approved trials going on. And the faster and better, the quicker we recruit to these trials, the quicker we will get an answer. So I think our time's almost up. I know there's lots of people whose questions haven't been answered. First of all, there'll be other speakers around to answer those as the program develops, and we will catch up again later. So a lot of questions have been asked about face masks, and I'm hoping that our next session, which is Tuesday, 12:30 Tuesday, we're hoping to get Matt Hancock, the Secretary of State for Health, on, and I'm quite sure he will be well placed to answer that and many others. Also on Thursday, we will definitely have Professor David Heyman, who, when it comes to pandemics, is the expert's expert. And in between, at a slower pace, on Wednesday evening, I'll be talking to historian Andrew Roberts about leadership in a time of crisis. So thank you ever so much, Peter, for being what I knew you would be. I've known you for a while. So clear and precise where precision is possible on the matter of the virus and its treatments. And to remind other people also, if you're listening, please continue to support the RSM in our mission to bring clinical expertise to bear on this problem and to provide forums for clinicians to talk to clinicians. And so once again, for all of those who remember Hill Street Blues, thank you for listening and be careful out there.
Thank you.